Hey friends, welcome back to Pathology. Today's video will be a continuation of our previous video which talked about staging. The link to that video will be linked in the description below. Now let's get right into it. First off, we should define what grading is and why was it instilled. Grading was introduced to assess the rate of progression of periodontitis at initial examination in the absence of direct evidence of progression. What I mean by direct evidence is it is the previous oral radiographs taken that we can compare recent radiographs to. Now, why should we grade? Grading was advocated to estimate future risk of periodontitis progression, estimate responsiveness to standard therapy, estimate potential health impact of periodontitis on systemic disease, and the reverse. But what is the need for such an approach? Well, it's merely to guide intensity of therapy, systemic monitoring, and co-therapy with medical colleagues to determine the likelihood of the case progressing at a greater rate than is typical for the majority of the population or responding less predictably to standard therapy. Let's explain this table in detail to provide a guide to grading. First off, the rate of progression could be slow, which is grade A, moderate, which is grade B, or rapid, which is grade C. Now, before we begin, a dentist should always assume the patient is a grade B before shifting the diagnosis to A or C, since a moderate rate of progression is more common. Now, on the left-hand side, we have primary criteria and grade modifiers. Primary criteria includes two types of evidence that we can utilize to reach a grade. One is direct and the other is indirect evidence. Direct evidence of progression should always be employed unless it was not mentioned in the question. In that case, we should use factors under indirect evidence. Direct evidence includes older diagnostic quality radiographs that we can use to calculate the amount of bone lost in the last 5 years. This value should be given in the question. If no bone was lost in 5 years, which is very rare since periodontitis is a dynamic disease that does not stop but can slow down, then this is grade A. If less than 2 mm was lost in 5 years, it's grade B. And finally, if more than or equal to 2 mm of bone was lost in 5 years, it's grade C, which usually represents what was previously known as aggressive periodontitis and is now called a molar incisor pattern. Moving on to indirect evidence of progression. Indirect evidence includes two factors. One is percentage of bone loss over the age and the other is case phenotype. Firstly, the percentage of bone loss used in this equation should be of the worst affected tooth. Secondly, the percentage will be either already measured and given in the question, which is not very common, or we'll have to estimate the amount of radiographic bone loss from the pocket depth, which is the more probable case scenario, or you'll have to calculate it from a given radiograph. In this video, we'll mainly focus on the first 2 points mentioned. If the percentage was already given in the question, we rely on that for the calculation, but if it was not given, we'll have to use the following table to reach a diagnosis. From this table, we can infer that if the probing depth was 4 or less, the radiographic bone loss will be 15%, indicating that 15% of the root length is exposed. If it was 5, then it's 33%, if it's 6, then it's 40%, and so on. 30 mm pocket depth will mean that 100% of the bone was lost radiographically. Something to note is, to follow these estimations, there should be no recession recorded in the chart. The minute we have recession, we have to calculate the clinical attachment loss and use that instead of pocket depth to find an estimate of the radiographic percentage of bone loss. This will be clarified in an example at the end of the video. After figuring out what the percentage is, we divide it by the age given in the question. If the answer is less than 0.25, it's grade A. Between 0.25 and 1, it's grade B, more than 1, and it's grade C. We also have case phenotypes. Case phenotype A represents heavy biofilm deposits with low levels of destruction, which is quite rare. Case phenotype B presents a case that has amount of biofilm reasonable with a level of destruction, while case phenotype C presents aggressive destruction that is not reasonable with the minimal amount of biofilm present. Moving on to grade modifiers. Grade modifiers modify the grade by the presence of risk factors such as cigarette smoking and metabolic control of diabetes that affect the rate of progression of periodontitis. A quick note, keep in mind that 1 pack of cigarettes contains 20 cigarettes. So a non-smoker is grade A, a patient who smokes less than 10 cigarettes per day is grade B, and more than or equal to 10 cigarettes per day, which is half a pack or more, is grade C. A non-diabetic patient is grade A, a diabetic patient with HbA1c of less than 7% is grade B, and more than 7 or an uncontrolled diabetic is grade C. Now let's put our thinking caps on and let's grade this patient. Take the original table that we explained previously and follow it step by step. Let's read the question. The question says that the patient is a 60-year-old who smokes 10 cigarettes a day and also mentions that the chart represents the condition of the entire dentition. Does this question mention that the patient has previous x-rays that we can use to compare differences in bone loss? No, so we have to shift to indirect evidence. Always assume the patient is grade B until proven otherwise. Since the percentage of radiographic bone loss was not given in the question, we will rely on the pocket depth to find an estimate. A pocket depth of 5 mm will equal 33% of radiographic bone loss, so 33 divided by 60 is equal to 0.55, which means this is grade B for now. In the question, it says the patient smokes 10 cigarettes per day. This will modify our grade from B to C. What if there was a recession of 2 on tooth 1-7? In this case, we have to calculate cal, which is the pocket depth plus recession. So 5 plus 2 will be 7 here, which corresponds to 50%, and 50 divided by the age, which is 60, is equal to 0.83, which is grade B. In the question, it says the patient smokes 10 cigarettes per day. This will modify our grade from B to C. Another case could be, what if instead of a smoker patient, the patient is a diabetic with HbA1c of 8? In that case, the grade will immediately shift to C. So this will be it for today. I hope you found this video helpful. Please hit the subscribe button if you would like to get notifications of our upcoming videos. And thanks guys. Take care.